I want to say good morning. I'm Allison Ferguson. I'm the Chief Operating Officer at the Scattergood Foundation. And we partner at the foundation with 3 other foundations to run the Think Bigger, Do Good policy series. And this webinar today, promoting the mental health of parents and children by strengthening Medicaid support for home visiting, is part of that series. We'll get started in just a moment, and we're gonna do a few housekeeping items for everyone. This is being recorded, and the recording will be available for everyone on the Think Bigger, Do Good YouTube channel and website, and we'll also disseminate it afterwards, as well as any material that we talk about in the paper from the paper series. So everyone that participates or is registered will get that as a follow-up. We do have the Q&A feature open on the Zoom, so please send questions through that. I'll be keeping an eye on it and get those to the speakers and panelists, and we'll at the end of our time work through any questions the group has, and then also if there's anything that we don't get to, we will work to follow up with you all offline after the webinar. Again, I just want to say thank you to our partners at the PEGS Foundation, the Patrick P. Lee Foundation, the Peter and Elizabeth Tower Foundation, that have worked with the Scattergood Foundation over the last 7 years, I think, on the policy series to make this happen. And then we also have a unique and special partnership with psychiatric services, that allows us to work together, and we publish some of the work that is included in the series and help to disseminate this. So always wanted to say thank you to the team there. We're gonna hop right into the webinar. Today we are joined by Elisabeth Burak, who's the Senior Fellow at Georgetown University McCourt School of Public Policy and Center for Children and Families. Vikki Wachino, who is the principal at Viaduct Consulting and former Deputy Administrator of the Center of Medicaid and Medicare Services. Ireta Gasner, who's the Vice President of Illinois Policy at Start Early, and Howard Goldman, who is the editor for the Think Bigger, Do Good series, and he's going to be moderating this wonderful group of ladies here that have so much knowledge to share on this very, very important topic. So I'm going to get out of the way and let Howard take it over.
Thanks, Allison. Let me join you in welcoming all the participants in our panel here. It's a real pleasure for me to focus on this. I first heard about home visiting when we were preparing the Surgeon General's report in the late 90s. Hard to believe it's almost 25 years since the report came out, and the chapter on children had a feature of the research of David Olds on nurse home visiting. And it kind of then left my radar, and I thought, like all things, it was being implemented and I just hadn't heard about it. And that turned out not to be quite true. And the policy papers series has an advisory board, and an idea to commission a paper on home visiting came up, and I was surprised that it needed more attention, but very pleased to focus attention and learn more about the challenges of implementing home visiting. So I'll get out of the way, as Allison did, and start with our panel. We're going to start with Elisabeth Burak, who's going to tell us more about what home visiting is, about some of the implementation challenges. Then we'll shift over to Vikki Wachino, who's going to talk about Medicaid and its role in implementation. Then we'll have a reaction from Ireta Gasner from Illinois. So why don't we just get started? Elisabeth, why don't you tell us what home visiting programs look like? What are they, and how do they function?
Sure, thank you so much. And thank you, Howard, for allowing us to sort of have this very conversation and do this paper, and especially to the Scattergood Foundation and all of the other Think Bigger, Do Good funders, because we feel really strongly about this piece. So when we talk about home visiting, the way we highlighted it in the paper is sort of a holistic 2-generation approach that supports parents and children during pregnancy, through the newborn year, and many may continue through a child's age 5 or before they get to kindergarten. And the services, and these vary by different models, which we'll talk about, but the services typically involve some combination of screenings or broader health assessments for the mother and the child, and then using the results of those screenings to connect families to the services they need in the community or other services at home. Parent education or coaching that's designed to help promote a child's social emotional development and interaction, really serving that relationship between the parent and child. Many home visiting programs, and most of them, I would say, have a sort of offer a connection point and sustained care coordination to link and refer to services outside of the home, including, since we're talking about this, mental health supports in response to screenings, as we mentioned earlier. And then some models incorporate home-based treatment, including dyadic or family therapy that supports that parent and child relationship building. So if the family is seen as needing more intensive supports or treatment, some home visiting programs will embed that service, and Child First is one that comes to mind. So in terms of models, we highlighted 19 in a supplement in the paper that are demonstrated to have child and maternal health outcomes, and we listed some of the mental health outcomes that they've seen. But some of the models that we highlighted that we know have really good maternal and child mental health outcomes, Child First is a model that has a mental health focus, and it supports pregnant women and children from birth to age 5. And it brings in licensed mental health clinicians and care coordinators to visit really frequently in the first month, and then they adjust those visits based on family input and what the family needs over time. And as I mentioned, they're one of the models that embeds treatment, specifically child-parent psychotherapy, in the model for families that need it. You mentioned David Olds, Howard, and Nurse-Family Partnership is one of the longest studied over many decades models. Nurse-Family Partnerships uses registered nurses to begin visits. You have to enroll during pregnancy, and they go up to age 2. And it's really sort of a nursing process that the nurses do clinical assessments and do individualized goal settings with the families. But I think it's important to know one of the other models that has mental health outcomes that you can see doesn't necessarily require a licensed practitioner like a mental health or a licensed nurse. Healthy Families America uses trained community members to visit homes at least once a week for the first 6 months after a birth. And again, those visits become less frequent, and it depends on the family needs. But Healthy Families America provides screens and assessments, particularly for families at risk of child maltreatment or adverse childhood experiences. And then they do routine screenings and assessments over time and connect families to services, particularly around maternal depression and child behavior. That's just a snapshot of sort of what those models might look like for families.
Sorry, I was on mute.
That's okay.
Thanks for reviewing those models. You know, I was familiar with the nurse home visiting approach, but it's interesting to see that there are lots of different kinds of professionals and paraprofessionals who are involved in some of the models. There also was a narrow target, if I remember correctly, in Olds's work. But as I understand it, that's broadened somewhat. It's not second pregnancies and only at-risk mothers, and is that correct?
As I understand it, the model, Nurse-Family Partnership is focused on first-time pregnancies, and you enroll during pregnancy right through the infancy. And that's a good question. Someone who knows an FP might be able to weigh in on whether that's been broadened. But there are other models that serve families after birth. They'll serve second pregnancies, and I think one of the reasons we didn't want to focus exclusively on one model is that, you know, different models can meet families in different places.
Well, it's just interesting to see how the idea has evolved from the times of the first clinical trials that were done in the 90s. Could you review with us a little bit about the outcomes that people have come to expect from home visiting? Something a little bit
absolutely
about the research and outcomes.
Well, I will say we relied heavily on the HHS evidence review of home visiting models, which I'll put in the chat once we're done here, but the most extensively researched home visiting models, and I should say to be in this evidence review, you have to meet a very high standard of research. But these models have demonstrated outcomes broadly in child development and school readiness, child health, linkages and referrals to services, family economic self-sufficiency, maternal health, positive parenting practices, and then reductions in child maltreatment and in juvenile justice involvement. So in the paper, in the supplement 1, we highlighted the 19 models that we knew had child and maternal health outcomes, and specifically mental health outcomes. And I mentioned a few that had mental health outcomes. Another one for the parent or the child. Another is early Head Start and home-based option. For those of you familiar with Head Start, there's an early Head Start that has a home-based piece, and Family Spirit. Those are the two besides Child First, Healthy Families America, and Nurse Family Partnership, where you see pretty extensive mental health outcomes. And specifically, you'll see for maternal health, reductions in anxiety and depression, decreased stress, better feelings of self-empowerment. For children, improvements in social emotional development, behavioral health, emotional regulation. And for the Nurse Family Partnership, for kids, later reductions in substance use at age 12.
Yeah, the earliest research was really very impressive in terms of its impact on maternal depression, and also how, the longer term child impacts. Does it get mediated by referral and access to other behavioral health services, or is it more a self-contained approach where the mental health supports and treatment occur within the program itself?
Well, that can vary. That can vary. I think sometimes it's about those connections. And like I said, there are models that one of the things we try to differentiate because of Medicaid, sort of thinking about Medicaid's involvement, is there are a lot of services, especially health services or mental health services, that can happen in the home. And there are some models that will refer to services that might happen in the home, but might not be embedded within a model. Or in the case of Child First, for example, which has a very explicit mental health focus, they actually will incorporate child-parent psychotherapy inside the home visiting model. And they might be connecting with other resources, but they sort of organize that. So it really varies. I think
it varies.
One of the, that's kind of the theme of this. It can vary a lot.
Yeah, there are a lot of models. But unfortunately, I've come to learn that implementation hasn't been lightning fast, like I kind of expected after the results. So naive 25 years ago. But why don't you tell us a little bit about the implementation of home visiting programs across the country, and then something about the challenges associated with that?
Sure. I think one of the, this, as you say, there's evidence on home visiting from over many, many decades for some models. And you would think that would be a natural opportunity to spread. But I think we still know that home visiting, these comprehensive models that we're talking about, only reach a small fraction of the families who might benefit the most. 4% is the estimate in 2021 that the National Home Visiting Yearbook suggested. And that could have gone up. We're not sure, but the maternal and infant early childhood home visiting program which was created in 2010, was the single largest federal investment in home visiting in recent years. And even with M.P.P, which is those of us who think about this a lot, call it M.P.P, we're still only meeting a small fraction, maybe 4%, no more than 10% ever of the families who might be most in need. And that, of course, varies by state. So that is kind of why Vikki and I felt like it was really important to talk about the opportunity here for Medicaid to do more, which she'll talk about those. But I think the challenges beyond just, the first challenge I think is funding, right? Even when we have this dedicated pot of money of discretionary funds at the federal level, we have to keep re-upping that funding pot every few years. It just got an additional boost earlier this year. That's still only getting to a fraction of families. And I think that, because you have so many different models and different systems that rely on these models. There are models that are sort of looking at preventing child welfare involvements. You've got models that are looking from child welfare. You have models that are promoted by the health and early childhood health world or early childhood and development world. Sometimes we don't think across these models at once in this larger picture of home visiting. So I think while there's a lot of support within certain systems, maybe there's not a collective groundswell of, let's think about how we can grow all of these models to meet different families in different places in their communities. So I think it's funding and to some lesser extent, sort of trying to think about how to align the various groups behind the approach overall, and then think about how to align the models.
Okay, well, you focused in on funding, on financing approaches, and that suggests Medicaid, and we have a real expert here on Medicaid to ask questions about Medicaid support for home visiting programs. Drawing on your experience both at Medicaid federally and then subsequently, you want to tell us about using Medicaid to expand and improve implementation of home visiting programs?
I sure do want to tell you about that.
I'm not surprised.
First, thanks to Scattergood and your partner funders for supporting this work. Thanks, Howard, for really being the linchpin of this conversation and the project. And thanks especially to Elisabeth, who's just a great collaborator. And thanks to everyone who joined us this morning. This is such a great way to start the work week. As you've heard from Elisabeth, the evidence around home visiting's impact is so compelling. It's particularly compelling, and this is what brought me to the table and wanting to think about this work, is like we have what's widely regarded as a crisis in mental health in this country, and many, many people who are in need of assistance. And so the opportunity to look with Elisabeth specifically at the mental health impacts of home visiting was very compelling. And it really strikes that, we're trying to work as a society towards these broad set of urgent national goals around mental health, which is probably the primary interest of many in this audience, around school readiness, around substance use disorder, and around reducing involvement in the criminal justice system. And there's an opportunity through home visiting to advance all of those goals at a time when greater progress is badly needed. We've seen really solid progress in home visiting and making home visiting more available to people since the creation of M.P.P. in 2010. And that really has both relied on and built on decades of evidence on home visiting's impact. Yet home visiting still, as you've already heard, is available to only a small sliver of the children and families who might benefit. And Howard put his finger on it right from the gate. We've got this gap between evidence and practice. And so really the question Elisabeth and I asked ourselves as we did this work is, how can we take this effective intervention and really prime it to scale and reach many more of the children and families who could stand to benefit from it? And the answer we quickly came to was Medicaid, and specifically to classify home visiting as one of the services that state Medicaid programs are required to cover, so that all states would cover it throughout a child's first year of life, and states could, at their option, cover it beyond a child's first year. Why Medicaid? Simply put, Medicaid reaches more children in the United States than any other program. 40 million children, half of all children are enrolled in Medicaid. 12 plus million children under age 6, 2 million infants in the United States. So Medicaid is a highly effective lever to scale and reach children and families in the United States, and reach low-income children and families who are the people who are in greatest need of these services and could potentially stand to benefit from it the most. Medicaid's also the major financer of maternity care in the United States, financing more than 40% of all maternity care. And because race is correlated with poverty, Medicaid's role to Black and Hispanic families in the United States is even greater. So Medicaid's reach is the primary reason. In addition, though, funding these services through Medicaid can really enable connections between these services and the other services that Medicaid covers, whether those are preventive services, mental health services, intervention services. And then finally, you've already heard from Elisabeth about the critical role of financing. Although funding for home visiting at the federal level has increased, it is funding this through discretionary funding alone is very unlikely to meet the need for services. But bringing Medicaid to the table in a stronger way can really help move the needle. Now, Medicaid, let's be clear, already playing a role. At the time we wrote this paper, we estimated that 21 states covered home visiting. The National Academy for State Health Policy has since updated that number, so 28 states cover home visiting, and that's a solid number. But more could be done. Even in those states that cover home visiting, those services are targeted to specific populations or specific geographies within a state. So we really have a lot of progress that we could make through Medicaid. Although we suggest that home visiting coverage should be required for states, we want to couple that with state flexibility on what models are actually covered. As you've heard from Elisabeth, and you can admire her handiwork in the supplement, where she looked at such a diversity of models and their impact, there are a lot of opportunities out there to design specific home visiting programs using models that already exist. There is no one model. There are many, many highly effective models, and states can choose from among them, and can do so relying on a strong evidence base, including the evidence base that HHS has helped to strengthen over the past few years through the M.P.P program. States could also really advance the ball with emerging workforce approaches like community health workers and doulas. So there's a lot of opportunity for innovation in the home visiting space, and we can really accelerate that innovation by relying on Medicaid.
Right,
Now,
Vikki,
strong, yep, sorry.
Let me interrupt you just because
Yep.
I want to shift to focusing on the recommendations that were in the paper. And if there's some other things in the background, you can weave them in. But you talk about making the evidence-based home visiting program a required state benefit. There are challenges in doing that, right? Medicaid is involved in 28 states, so that's part of the plans. We are focusing advocacy on expanding it further, and you focus on making it a requirement in a state plan, as I understand it. Do you want to share with us what some of the challenges are in doing that? It is a way to make it more sustainable. That's what I understand from your work.
Yep, that's exactly right, Howard. And I think the challenge is that we're not going to transform these systems overnight through financing and coverage alone. We really need to build the capacity of the system. And so our recommendations highlight not just, flipping on the switch and making Medicaid cover these services on a mandatory basis immediately, but starting with a state option so that states could build capacity over time. A critical need will be grant and technical assistance support to states as they build out these services, including attention to developing the workforce. And then additionally, there's a need to, and there will always be a room and a need for grant funding like M.P.P. But states really need some assistance from HHS in understanding when you use a discretionary program like M.P.P. and when you use Medicaid. And to be clear, that need exists right now, regardless of whether we change anything with respect to federal Medicaid policy.
I see. So the ultimate goal is to have a mandated benefit, but also to keep discretionary programs that support home visiting as well, so that they would be braided or blended together for funding? Exactly.
It is not an either or, it's an either and. Medicaid is a coverage source, as you know well. It covers services, right? But Medicaid is limited in its ability to cover infrastructure and to help with things like workforce development. So there's always going to be a role for federal grant fundings, and that's not unusual. We see that in a variety of domains where Medicaid is primary lead on getting the health services to the people who need them, supported by grant funding that can help develop infrastructure, capacity, et cetera.
But you're also calling for technical assistance from the federal program, I guess, to add resources to help programs and states know how to coordinate various funding streams and how to implement. Is that
That's exactly
a correct
right.
reading?
If you're working at the state or the local level, sometimes your experience is, I'm getting all of this direction from these different financing sources, and I have limited capacity as a state, as a local government, as a provider, and so having HHS step up, in ways that is similar to ways that they're already doing, but in a stronger, maybe slightly more assertive way, to actually help state and local leaders understand the differences between the financing services. I think it's always helpful when HHS aligns at its level some of the funding parameters, so that states feel like they're getting similar directions from CMS, HRSA, et cetera, ACF, rather than different instructions. So that's the way I think that that HHS could additionally be helpful in moving the ball forward. Let's go ahead.
Medicaid is a broad program. I mean, it's broader than most commercial insurance programs. It's broader than Medicare for sure. But it still requires medical necessity. Is there a challenge there? And is that somehow how having braided funding and other funding sources help to flesh out the intervention itself and be able to fund all the aspects of home visiting?
Medicaid has a lot of tools that help ensure that people who really need the services are the ones that get them. So, I think, the challenge with medical necessity in early childhood sometimes is that states for other services for older children and adults require diagnosis requirements, whereas for early childhood services, and just to be clear, I've learned all of this from Elisabeth, for early childhood services, requiring a diagnosis is, requires waiting too long. These are services that you really need to deliver right out of the gate to a new family, to a family with an infant. And so I do think there's some, we want to make sure that access to these services is low barrier, right? And so many people are getting them. Also, in contrast to some other services that the health system funds, these are not high cost services, right? This is a discrete intervention with potentially high impact. And so it really should be broadly available.
Yeah, that's great. Well, you mentioned Elisabeth again. I wondered do you have anything to add about this before we go to our reactor, Ireta Gasner?
My only addition, and Vikki said it well, is that, unlike for adults, Medicaid has this built-in requirement to provide preventive services to children. And so that kind of medical necessity is definitely an adult-focused piece, whereas you can definitely define home visiting as a preventive service. And I think a lot of the interpretation issues come out, and the lack of funding, frankly, and focus on young children during this really specific early stage of development can get in the way of what the federal requirement might be.
Well, it may be an adult focus, but it's often used by opponents of modernization and expansion of Medicaid, who fall back on medical necessity criteria and a diagnosis. Is there a clear opposition to this, or do you anticipate that this is a change in Medicaid policy that we can expect to see in the near future?
I don't see a lot of opposition to this. Honestly, I think historically there's been a very nice and impressive bipartisan commitment to home visiting generally. I think there are always questions about, when you're putting a new requirement on states that come up. But honestly, I think the evidence here is so compelling that this could have a significant impact on children and families. And again, help advance a set of national goals that are commonly held across the political spectrum around mental health, around addiction. around the need to support children. That, you know, I'm really optimistic. And the only other thing I would say is, although like this change would require legislation through Congress, we don't need to wait for Congress to act to advance services for home visiting. There are a lot of opportunities at the state level to expand access to home visiting. We're going to hear from the work in Illinois in just a second. The most obvious near-term lever is nearly all states are expanding the availability of postpartum coverage to new moms through Medicaid. And as they advance those services, embedding home visiting in them is a way to advance maternal health, mental health, child health, all at the same time.
Well, that's a perfect transition. You already set it up. We have Ireta Gasner from Illinois, who is going to talk to us about her experiences in their state with home visiting. You want to react to what you've heard from Elisabeth and Vikki, Ireta?
Yeah, absolutely. I'm so happy to be a part of this conversation. I'm grateful for the invitation. We're very proud of our home visiting services in the state of Illinois, which I think are probably among the longest standing across the country. And for those who might not know, Start Early is an early childhood program, policy, and research organization. And our own birth story actually is in home visiting in Illinois, where we partnered very closely with state government and the legislature to actually begin these programs with state funding, as I mentioned, 4 decades ago. And so unlike many states, when the M.P.P program was created that Elisabeth mentioned, we began the process of blending and braiding and layering funding once those federal dollars came into the state. It resonates for me, the sort of 2-gen multidisciplinary approach that the article references. Much of our work really began in the child welfare and parent engagement, parent support space. That was before we called it 2-gen, but we were doing that 2-gen work then. I think as the focus across the country focused through some of the brain science on the early years and early childhood development, we began talking about home visiting through that lens alongside the child welfare lens. There's now much more incorporation about the health impacts, which we've long tracked, but haven't often linked quite so intentionally to the supports. So we've had state funding, as I mentioned, for 40 years. And then in 2018, our Department of Public Health issued a report around the racial disparities in maternal morbidity and mortality and lifted up Medicaid financing for home visiting, doula supports, as well as universal newborn support systems in those findings. Our primary role on my team is actually policy and advocacy. And so we initially helped file some legislation to advance this notion. And then in the summer of 2020, our Illinois Legislative Black Caucus, sort of in the wake of the George Floyd murder and the civil unrest in our country, wanted to pull together a package of sort of racial justice bills. And one of them was a package incorporating health and human services. And we were able to take the legislation that we had filed and have that incorporated as a part of that package, which was finalized in early 2021. So while we may be one of the old kids on the block for having home visiting, we're a little behind some of the other states and actually looking at how to incorporate Medicaid into that. Just a couple features, I think, of our home visiting system that I would like to be sure to folks to be aware of is that we have embedded infant early childhood mental health consultation in home visiting for some time, which is not a clinical intervention, but a support to the home visiting program itself for how best to respond to the social emotional needs of families and children. We've also, not just Start Early, but other partners, we've piloted other interesting innovations with other populations, working with families experiencing homelessness, working with teen parents who themselves are in our child welfare system, refugee and immigrant groups. We have a partner, a hospital partner who's doing the ACEs survey on pregnant parents and then referring some of those families with high ACEs scores to at longer term evidence-based home visiting. So a lot of interesting work has been done over the years, and the conversation about models and what can fit best in a community has been our longtime approach, where communities can sort of within a range of some of the evidence-based models, are able to apply for and select the model they think will work best. And I think there's a lot of interesting conversation to have about some of the populations I've referenced and how, to the extent to which our current models might better serve, or whether there are sort of innovations in models to yet occur across the country.
One second, Ireta, do I understand correctly that within Illinois, there are a variety of models of home visiting that you use? There's not a standard that's been particularly tested, but over time you just allow the ideas to be adapted to local conditions and local interests?
I mean, there are some parameters. The longstanding programs in Illinois are Healthy Families and Parents as Teachers. And then when the Home V list came out, again, that Elisabeth referenced, the state has been tying more closely to those models. And there is state infrastructure and training supports and things like that that do follow with the models. And so there is some choice among models in the state. And I know in M.P.P, there was language around promising practices and getting an evidence base for that. We do have one longstanding model in Illinois that has been working toward getting that recognition within the Home V. So I think, again, what we have done is work within the standard models, and then sometimes work with the models to tweak or look at where there might be some flexibilities, particularly with some of these innovative sort of population-specific programs.
Okay, I kind of derailed you. You can go back to your...
Oh, that's okay. No, I'm glad to have the questions. I mean, I would echo in many of the health benefits that you heard about. Start early. The state is the implementer, obviously, of home visiting. My program colleagues at Start Early do operate a set of those programs through federal and state funds, and show that our families are higher than the national average for being on track with well child visits and immunizations, more likely to get early and consistent prenatal care, increased initiation of breastfeeding, for example, increased connection to health insurance, referrals to Part C early intervention for children who might be showing developmental delays. Our families actually show lower than national average rates of maternal depression, but then really strong rates of connection to services, for example. So the connections are really clear. And I know my colleague, Kayla Gofarb, who's deep in the weeds on this for us every day, we did a fair amount of crosswalking between some of the models and the outcomes in order to have some of these conversations, both with the state Medicaid agency, but also with private insurance, to kind of help make the case for how home visiting actually can work in partnership with health insurance to help everyone move on the benchmarks that we know matter for children and families.
Great. Are there any things, Vikki or Elisabeth, that you want to ask or make sure Ireta clarifies from the Illinois experience? I know that's my job, but I thought you might have a question that arose.
I did want to just talk a little bit, because I know there was a question also. There was also a question in the chat that I wanted to answer. And I think Ireta mentioned, there's this very strong, M.P.P ties funding to very strongly researched evidence-based models. And one of the things Vikki and I wanted to put in the paper was that for this new requirement, states could choose among sort of the Home V models that have child and maternal health outcomes, but also have some flexibility for states to choose promising models or models that have emerging evidence that might not require randomized control or really, investments in that kind of research, so that states can also think about the kinds of approaches they want as well. For example, in Michigan has a homegrown model that is actually on the Home V evidence of effectiveness list. And that was based on their years of research, but there might be others that haven't had the benefit of really extensive research that states feel strongly about incorporating, especially when you're trying to reach hard to reach populations that we might not have researched enough on, tribal communities or families of color. So I think that we tried to add a little flexibility there, understanding that states also might know best what they're seeing.
Great, thanks. Your paper was really outstanding, and I was very pleased when my successor at Psych Services, Lisa Dixon, decided to partner with our Think Bigger, Do Good project, and she was very eager to include your paper. And of course, the evidence base is so important to the readers of psychiatric services. So this was a really nice interface between evolving policy-based research, outcomes-based research, and implementation issues. Now we've interrupted Ireta. I don't know whether you had some other things you wanted to share with us. There was also that nice illustration of how you're organized in Illinois. I don't know whether we were going to show that.
I think, yeah, we have
I think Allison has it.
there you
There
go.
it is.
And I think, you know, in thinking about some of the challenges and where federal direction and support to states is critical in early childhood, we're very used to blending and braiding early childhood because we're a pretty chronically underfunded sector. But so this is just an example of how dollars actually do flow within Illinois. And it's both interesting and a little complicated. And I think one of the things in early childhood broadly we're trying to think about is how can we make sure most of taking of those dollars and the pooling and the blending can actually happen at the state level? How can the Fed sort of support some simplification there so that otherwise what happens is those decisions really get pushed down into local administrators, and it can be a lot of work, but it is how we can actually knit together resources to really provide the kind of comprehensive supports that we know families need.
If you add Medicaid to this organizational soup, where does it sort of flow into the system? I'll ask a real nerdy question, but
Yeah, it would flow into the white boxes up there who are our state agencies. It would
Right.
add state Medicaid agency. And frankly, while the legislation was passed some time ago, they have still been working on that implementation because it is a complicated prospect. Because I think it will flow to all of those. Well, I shouldn't say that. I'm not entirely sure exactly how it will flow. I think it will flow directly to those home visiting programs who will then have sort of an additional agency with some reporting and, you know, fiduciary responsibilities that they'll have back up to that agency. So again, that's where one of the things we've tried to do in Illinois is to those blue boxes there underneath the white, those are sort of the agencies implementing, are very much a part of the implementation conversation. So we can think about how can we simplify, what are the impacts on those other funding streams, and how might those funds be used in a way that's definitely complementary, because to your earlier point, we still, because of the small reach of the programs, we need to maintain all of those other funding streams and programs and support services. So how do we sort of integrate Medicaid into that in a way that will make sense and not require a lot of additional reporting back to yet another federal agency or a state agency, sorry.
Right, that happens when you braid too many
Yes.
resource flows together, a lot of reporting burden. Anyway, we've come to the end of our formal presentation. I want to thank Elisabeth and Vikki for suggesting Ireta to come and make this real for us by seeing one state's implementation. Again, I previously complimented the paper. I suggest that folks on the webinar look into that paper. It goes into detail, is extremely well written. And I want to thank all our presenters for their contributions today. Now I throw it back over to Allison to handle the Q&A. But thanks for having me to do this moderating job, and it's been very interesting. Let's hear for some questions, Allison.
Yes, thank you, Howard. Much appreciated your moderating of this discussion. So in the Q&A, one thing I just wanted to raise from Claudia Schlossberg in DC, she has shared a link, and we'll make sure you all get this afterwards too, around new legislation in DC that is expanding the programs. And I think Elisabeth and Vikki had taken a peek at this before. So if you want to add any commentary on that, feel free.
I think my commentary, Allison, is that sounds great. Really excited to hear of the progress in DC. I wonder if it'd be great if we have time to hear if Ireta has advice from her experience trying to advance these services for places like DC or other places that are really trying to move the ball forward?
I fear we're a little early in implementation to fully have that advice, other than I think I think in our experience would just be trying to make sure you've got a range of stakeholders sort of advising on implementation, thinking broadly about the kind of folks who have a stake in this work and a role to play, so that we're hopefully not unwinding maybe duplication or confusion of services along the way. And I know the other thing that we've been advocating strongly for is being sure that there is some role for families and providers to inform what this looks like, to make sure we don't spend all that time building a system that doesn't really improve things for them. So I think that would be one other, maybe I'll just mention one other thing that relates to one of the questions around billing. And we're introducing providers who maybe haven't been a part of Medicaid before. And we have doula services as a part of our home visiting, but obviously there are also many standalone doulas in the state of Illinois. And this is our work is going to include Medicaid funding for them as well. And one of the recommendations that came from our state's home visiting task force was really to think about some sort of billing, at the very least, technical assistance center. And we have a model in our early intervention program of an actual sort of billing intermediary. The concern we raised is that if there's no support to folks for doing this, your big programs and your big providers who may already bill Medicaid or have that back office capacity will most be able to take advantage of this. And in fact, then the Medicaid funds are not necessarily hitting the smaller, more community-rooted organizations. So that is still work ahead. We don't have an answer on that one, but I think it's a really important question and should be thought of, particularly from that equity perspective.
Yeah, Howard, can I add to this? Because I know Illinois has thought a lot about it. And this is even in states that we know are using Medicaid to fund home visiting, this is a big challenge. Just having that on paper doesn't mean a community-based organization is able to build in this medical model way. And so I think there are, in New Mexico, as we understand it, they have dedicated liaisons in the state agency and in all of the managed care plans to make sure there's a point of contact for billing challenges and to make sure that that's available. Ireta mentioned a lot of states using intermediaries, and I think right now, as we're seeing more and more states think about community health workers and doulas and more of these sort of community engaged and embedded providers that we can use, it's an opportunity to take all of those pieces together and figure out what's the infrastructure to help these folks bill. We've already seen this a lot in early intervention and in the education system. The federal Medicaid agency just put out a huge billing guide for schools and Medicaid, has a technical assistance center. We could see that kind of thing for early childhood too. So I think there's a lot of room to think about this differently, both at the state and the federal level.
Great. And then I read this question: how does Illinois coordinate between all the funding streams, home visiting programs, to ensure they're reaching all parts of the state, aren't duplicating efforts, and reaching those in need? I know you touched on this just a moment ago, but is there any kind of good logistics and coordination tips that you can share?
Yeah, we've had sort of interagency tables in different forms over the decades. And so would strongly, again, recommend that those sorts of bodies be pulled together. It helps to have a governor's office that takes a strong hand in saying, we're going to do this together and we're going to use resources wisely. A couple of years ago, they actually kind of shifted the implementation of federal M.P.P from a separate agency. So now that same agency also holds some of our other state funding. So looking at those ways to sort of integrate and then align and work in a coordinated fashion. It's always a work in progress, of course, and good data is always key to it. And it's always a challenge when state agency data sets also don't coordinate. So we've also continued to try to work on and actually the M.P.P needs assessment has been a place where we actually as a state have said, let's not make this only about M.P.P. Let's actually use this opportunity to scan the wider system as well. And then that can help guide where M.P.P investments go as well.
Great. All right, and then we have it's from Claudia. Can you address challenges of working with MCOs?
Who wants that easy question?
I can try it, and Vikki, you should jump in. So for those unfamiliar with MCOs, it's managed care organizations. And I would say most kids and families in this country who are covered in Medicaid are covered by what's called managed care. And this is where the state contracts with, most of the time, private healthcare insurance plans to manage the care of their beneficiaries. And the simple answer that won't get you very far is that managed care organizations are kind of the filter by which the requirements of federal Medicaid and services to kids and families go through. And so I think one of the challenges, especially when we think about some of the federal benefit requirements for kids and these preventive services, is that if the state's not very explicit with the managed care organizations about their responsibilities and requirements, including things like home visiting, if that's a state requirement, then those contracts really drive, even if it's a state law. So I think, really intentional thinking with those managed care organizations. And I would say when we think about things like infrastructure for billing, we have states that are trying to make sure that, Michigan's one of them, that they give incentive payments for managed care plans that are hiring community-based organizations as opposed to hiring home visitors or others on their own, so that their money is getting back into the community and the folks that need it. So there's a lot to think about. I don't have a great answer. I think it really depends on the strength of the states to clarify exactly what they mean and what managed care organizations need to be doing. Vikki, you may have more to add.
I can envision an opportunity and a challenge with respect to managed care. The opportunity is that if the plan is actually integrating home visiting services into other services and really realizing the potential to coordinate care, which is why many states turn to managed care, then I could see real value added in delivering the services through managed care. The pitfall, which is not small, is that a lot of these requirements around medical necessity and diagnosis requirements are common managed care practices for a variety of good reasons. And so, I think to really enable access to services, the MCO should think about, really thinking and operating differently with respect to these and other childhood services, and not just making a blanket assumption that things like medical necessity and diagnosis requirements should pertain. To Elisabeth's point, all of that rests not on the MCO itself, but on state leaders. And how they write the contracts and what expectations they set for the MCO. The MCO is extremely unlikely to get to exactly the right place on their own. They serve at the pleasure of the state, and the state needs to set the policy, set the contract requirements, and oversee the services to make sure that kids and families are getting the services they need.
I'm glad you said that. I think that's a critically important point. They don't operate or shouldn't be allowed to operate on their own without state oversight and close monitoring that they're doing what it is that the state intended.
Great, and I'll just want to recognize Claudia put in the Q&As. It'd be great if someone could develop model contract language for home visiting for states to adopt.
Well, Claudia, if your bill passes, then that person might be you. Go to DC and share it with others. And Ireta, I don't know if these issues have already come up for you in Illinois around the role of the plans.
Yeah, and I mentioned earlier that Kayla, for example, one of the things we had done was just to crosswalk some of these health outcomes and looked at what are the things that the MCOs are actually accountable for to help make the case how, in fact, by working together, we can help achieve the outcomes the state is looking for children and families. We've had lots of conversations, even outside of the sort of who pays for this, of just how MCOs can be a stronger referral source for families, for example, where there's sort of no money on the table at that point. But again, just establishing how these partnerships actually can benefit everyone involved. And yeah, we're anxiously awaiting our state plan amendment. And I think some of these details will start to hopefully unroll in the near future for us. So love to keep folks updated.
So on the contracts piece too, I just wanted to add that Kay Johnson had a few points throughout the Q&A, and I want to acknowledge that all of the work that Vikki and I did was really based on decades of her knowledge and research, as well as the National Academy for State Health Policy that we've referenced. But she and the George Washington University have done a number of contract reviews for different language. I don't know if home visiting came up highly in a lot of those. I think generally there's a lack of attention on young children and families and managed care contracts that we're seeing more of, as we've highlighted for all these reasons. But we can also look to see if there's anything there or what she might recommend as well.
That's great. So it doesn't look like anything else has come in the Q&A. So give a few more seconds in case someone's furiously typing one last question. But I just wanted to thank all of our speakers, Elisabeth, Vikki, Ireta, for sharing your wealth of knowledge with us. Howard, thank you for being here as our faithful editor of the Think Bigger, Do Good policy series, and now moderator. We've added to your resume here with us. For all the participants, we will be sharing the Q&A and the links that were provided there, as well as what items we've shared in the chat. We'll be sharing the PDF of the paper that Elisabeth and Vikki wrote for us, as well as the slide deck. I know there's just a few graphics in there. We do have a follow-up survey, brief piece that will be in there. We ask you to take a few minutes and give us some feedback. And we'll share the video recording of this. So you can expect that in the next 48 hours or so, once we get the recording down from the cloud and up onto the website. We'll get it all out. And a few people had chatted and asked about a certificate of participation. We don't do formal certificates, but we do. I can verify for your employer that you were here and so forth. So I'll drop my email in the chat, and I can help anyone that needs that as well. Just see. There's a few thank yous to our speakers, but it doesn't look like anything else came through. So we'll sign off and wish everyone a happy, healthy 4th of July coming up, and in the beautiful middle summer that we have coming up.
Thanks for your support, Allison, and to all the foundations. This is a nice event. Thank you. Thanks to the panelists.
Thank you all. Great to be with you this morning.
Thank you very much.
Bye-bye.